Welcome everyone to the Spine Nevada Virtual Health Seminar on new non-drug treatments for diabetic peripheral neuropathy. This is Molly Canaday, Director of Integrated Marketing for Spine Nevada. We are excited to have all of you joining this evening. During tonight's virtual event, you'll hear from Dr. Andrew Su on the following topics. He'll provide updates in treatment for painful diabetic peripheral neuropathy and share some of the benefits of the HFX high-frequency spinal cord stimulation. He'll also share on who is a candidate for new non-drug treatments for painful diabetic peripheral neuropathy. We'll have time at the end of Dr. Su's presentation for question and answer, so please go ahead and submit your questions throughout the presentation through the Q&A box. Without further delay, I'll introduce you to Dr. Su. Dr. Su is board certified in physical medicine and rehabilitation. He completed fellowship training in sports and spine medicine at Columbia University and Cornell University in New York. Fellowship training is the highest level of medical education available in the United States. Dr. Su also has a master's of public health and epidemiology from the University of Michigan. He has experience in performing image-guided procedures for spine and musculoskeletal conditions. Image guidance helps allow physicians to precisely place the medicine during the interventional procedure. In addition to traditional injection therapy, Dr. Su is trained and experienced in spinal cord stimulation, as well as orthobiologics procedures such as PRP and bone marrow aspirate concentrate. He joined the Spine Nevada practice in 2017 after relocating from Wisconsin. I'll now turn the meeting over to Dr. Su. Thank you, Dr. Su.
All right, thank you for joining with me on this webinar. We're going to be talking about spinal cord stimulation and the role in peripheral diabetic neuropathy. So about me, I'm Dr. Andrew Su. I work at Spine Nevada, the Minimally Invasive Spine Institute in Reno, Nevada. Board certified in physical medicine and rehabilitation. I did my training at the University of Washington in Seattle, and where I did my residency. And then I did a fellowship in sports and spine medicine at Columbia University in New York City. You can find all about me on our website at spinenevada.com using that link and go to our webpage. So what is physical medicine rehabilitation, or what is a physiatrist? That's what we're called. Not a psychiatrist, but a physiatrist or physiatric medicine. The goal of physiatric medicine, or PM&R, physical medicine rehabilitation, is to enhance and restore the ability and functional ability and quality of life to any of those with physical impairments or disabilities, including that affecting the brain, spinal cord, nerves, bones, joints, ligaments, muscles, tendons. So it is overall very encompassing and melds multiple fields, including orthopedics, we have rheumatology, neurology, and overall functional care. So unlike other specialties, we try to focus on improving the quality of life first and foremost, and then help improve daily activities of daily living. So in that, we have specialties. One of the specialties is sports and spine medicine and pain medicine, which I practice. And we are skilled in doing both diagnostic medicine as well as interventional treatment options to help those with the different problems. So here at Spine Nevada, and what I like to treat include a variety of things, including orthopedic type of injuries, such as shoulder, elbow, knee, wrist, hand, ankle, feet, tendons, ligaments, and joint pain. So we got knee arthritis, back pain, neck pain. And then we also treat the spine-related issues, as mentioned before. And then we have people who have maybe like radiating sciatic type pain. We also treat that as well. We like to use these modalities in concert with physical therapy, and also potentially to help minimize and prevent the need for surgery, or even if surgery has been performed and someone still has some problems, we are involved in helping manage those issues. So when does one need to seek treatment? So some of those things may be chronic pain type injuries, acute type injuries, such as overuse injuries and training injuries, weekend warrior type injuries, anything that affects daily life and functional activities and limiting that, usually related to pain. You may have a reduced physical activity and avoidance due to concerns of pain or discomfort, and those may prompt you to want to come in and get evaluated so that we can help treat that. You may have worsening range of motion limitations, such as due to the pain related to your hip pain or your back pain or your neck pain. And you may want to come in at that point as well to come be evaluated, especially if you have any weakness, numbness, or pain in the arm and legs. So what is pain? Pain is kind of everybody kind of seems to know what pain is, but what is pain? Pain is literally what the brain interprets. The brain is the computer that senses whatever else is going on in the body. The information is sent to the brain via nerve pathways. It come from your hands, it come from your feet, and go all the way up through the legs, to your spine, and then to the brain. So the brain interprets different sensations. It can be important sensations such as hot and cold, soft and light touch, and then also if we're hurting ourselves, if we do a step on a nail, we get pain to help tell us what is going on. Pain can differ enormously among individuals, and they may have identical injuries or illnesses. It is multidimensional, meaning it affects both the physical pain component, it affects your emotional component and mental components as well. So peripheral neuropathy is what we're going to be talking a little bit more about today. Peripheral neuropathy is nerve damage outside of what we call the central nervous system. The central nervous system is your brain and your spinal cord. Everything that your central nervous system connects to is the periphery. So that's why we call it peripheral neuropathy. So if someone has nerve pain outside of the central nervous system, they may have nerve pain in the arms or legs. It may be separate from their spine-related issues, such as a pinched nerve in the back. It may actually be nerve pain causing problems down in the feet, which is very common. And one of the main reasons for that is diabetes. So diabetes itself is very prevalent in the United States as well as in the world. It's estimated that 34.2 million people have diabetes. That's about 1 in every 10 people. In fact, diabetes doesn't happen often until later in life. There's both type 1, which is earlier in life, and type 2, which is later in life. And in later in life, people may not know until they have symptoms. They may go to the bathroom more, their weight changes a lot, their appetite changes a lot, they may feel more tired. And then when they get checked out, usually with a blood test, they are found to have diabetes and they've been diagnosed with it. So 1 in 5 people do not know that they have it until at some point later they are diagnosed with it. So amongst diabetes is the definition of elevated blood sugar levels. Now, if you have a high blood sugar level, we're designed as humans to operate within a sugar level optimal between 80 to 120 is the millimolar equivalent. So basically 80 to 120 when you do a blood finger stick. And then we have a test called the A1C. That one detects your average blood glucose level over 3 months. And then we have cutoffs for that as well. Now, if you're undiagnosed or if you are diagnosed and your sugar levels are higher than your body is able to manage well, then sometimes that blood sugar level becomes toxic, specifically to the nerves. So over time, the nerves can start to get damaged. Each nerve has a myelin sheath. The myelin sheath is a protective layer to help with the nerve signal. And if that signal gets disrupted, it can lead to numbness, tingling, pain, and sometimes severe pain. So that's what we call painful diabetic neuropathy. So we have non-painful diabetic neuropathy and then painful diabetic neuropathy. So amongst several large studies, it is estimated that 25 to 50% of patients with the diagnosis of diabetes will eventually develop neuropathy. So in peripheral diabetic neuropathy, that's PDN for short. There is at about 26.8 million patients who are diagnosed. There will be about 5.3 million patients diagnosed with peripheral diabetic neuropathy, which is about 1 in 5. That's what we mentioned before. And then out of those patients with painful diabetic neuropathy, the PDN, they will have conservative treatment, which we call CMM, conservative medical management. And some may respond to that, but a vast majority won't respond to that, or not majority, a significant portion of it, which is about 45%. So what are those conventional treatments? So if you got this, you have diabetes, maybe you got it under control, but now you're starting to get symptoms in your feet or your hands. Specifically, it often develops in the feet first. Your feet start to become numb and tingling. Maybe you can't feel it as well. And then at some point, maybe it starts to become more painful. And then you go to the doctor, your primary care provider. Maybe you go to a pain specialist like myself. And then we diagnose you with PDN, painful diabetic neuropathy. And we will ask about how well your glucose is controlled. So first thing we want to do is try to optimize that glucose control with medications that you're on or medications that your primary care provider can improve upon. You may have an endocrinologist that we also will recommend you see to help optimize that if you have one. And then after you optimize the glucose control with medications to help bring your sugar down close to within normal limits, then that might help. We may also recommend prescription medications such as nerve pain medicines. Those are the anticonvulsants. So those are the gabapentins, the pregabalins, which used to be called Lyrica. Those can help slow down the nerve signal to help with the pain. There's other medications like SNRIs, which are antidepressants, and other types of antidepressants called tricyclic antidepressants. And those affect the neurotransmitters. We have serotonin and nortriptyline, and serotonin and norepinephrine and epinephrine. And so these medications will help change the nerve pathways and how your brain processes those signals so that hopefully it won't be as painful. And then there's other pain medications. You can take anti-inflammatories. For severe neuropathy, some patients may try opioid type medications. They have their pros and cons. And sometimes they just don't work, okay, for this kind of problem. We sometimes will recommend topical treatments such as lidocaine, which is a nerve pain medication to help dull the signal. But it doesn't last very long, and it doesn't penetrate very deeply. And then you have capsaicin, which is like a pepper type medication. It actually causes increased pain temporarily before it starts to work. And most people can get through that, but it's worth trying. We'll recommend physical therapy to help with proprioception, getting the blood flow to improve your musculature. Sometimes that helps compensate for some of the pain. And then there's a device called the TENS unit. It stands for Transelectrical Nerve Stimulation. It's basically a little pad that you can put on top of your skin to help with electrical activity, to help decrease pain. And it might reduce the some, but sometimes it doesn't work, and it's a little cumbersome to use all the time. Okay. So we're going to go into, there's a lot of heavy data in the next few slides, but the goal is to try to demonstrate what we're going to be talking about, some of the new therapy that we can provide here at Spine Nevada. So in the diabetic journals, there were some studies that were trialing what's called Nevro high frequency 10 kilohertz therapy for painful diabetic neuropathy, or PDN. And they were looking to see if this would help with some of the symptoms related to painful diabetic neuropathy. So one of the major studies, probably the most landmark study for this, is by Peterson and company. They did a study for 12 months, and then it's gone over that now. They had over, I think, almost 200 patients go through this trial, and it was randomized. So meaning some people got the Nevro 10 kilohertz spinal cord stimulation study, and the other ones didn't. And 86% of these patients who received the Nevro 10 kilohertz study were in that study arm reported pain relief greater than 50%. So that's 86 of patients or participants reported pain relief greater than 50%. Even when these patients decided to have the option of crossing over to the treatment arm, which is the 10 kilohertz arm, 93% of those wanted to do that, and compared to conventional management. After 6 months of treatment, 84% of the crossover arm, people who switched over from conventional management to the 10 kilohertz spinal cord stimulation study, reported pain relief greater than 50%. At 12 months, 68% of the 10 kilohertz SCS treatment arm reported relief, okay? And so only 5 out of the 154 devices that were implanted were actually taken out because of different reasons, and those were really due to infection. Okay, so next study is by Chen et al. And company. This one was looking a little bit about looking back at the data. So this we call retrospective review. And they were looking at over a period of 2017, May of 2017 to November of 2020, looking at the data. They were looking at all the patients who had the Nevro system and being tracked. And they were looking at a time frame average about 21.8 months after we're getting it put in. 79.5% of these patients, 58 out of 73, reported greater than 50% relief. And so you can see in this study that the responder rates were actually pretty high again, close to 80%, and they're stable. And they're reporting relief at 84% reported relief at 12 months and 88.9% reported relief at 24 months. Okay, and so here's another one. We have Strand and Berkey talking about neuropathy and the review of evidence. In this basically summary study, they said the 10 kilohertz study offers several advantages over low frequency or traditional spinal cord stimulation, and has improvement in treatment success. We call it paresthesia independence, meaning you're not feeling the spinal cord stimulation, it's just working. And then evidence of improved neurologic function. And that may be you're able to walk better, do activity better, have less pain. So what is spinal cord stimulation? I know we've been talking about this a little bit. Basically, it's using these electrodes and that stimulate small electrical pulses to the spinal cord to block signals sent to the brain. So it's interrupting the pathway as the nerves come from the feet up through the spinal cord, really along what's called the posterior columns or dorsal columns. And so another term for spinal cord stimulation is called dorsal column stimulation. But it's going in the back of the spinal cord in what's called the epidural space inside the spine to interrupt those pain signals as it goes up to the brain, okay? It's very well established. It's been studied for decades. It was approved by the FDA in 1989 to help relieve chronic pain from nerve damage. Originally, the frequency range was 2 to 1200 hertz. And now with Nevro, they've gone up to 10,000 hertz. So HFX therapy or HF10 therapy, however you want to call it, a Nevro 10 kilohertz therapy. There's a lot of, there's controlled trials that show that in patients with back and leg pain, over 80% of patients achieve 50% or greater pain relief to 12 months and even longer. The product has been out on the market for quite some time, and over 70,000 patients have been treated according to their database. And the thing about all spinal cord stimulators, at least the standard of care now, is we will trial, we'll talk to you about it. We will trial, if we decide to move forward, it's a trial. So the trial is anywhere from 5 to 10 days. Typically it's about 7 days. It takes about that time to figure out, is it worth it? Is it reducing your pain? Is your pain in your feet and your legs not as bad as it used to? Is your functional activity better? Are you able to do more activities? Are you able to go walking a little bit longer? Able to go shopping, do activities without thinking about it as much, or taking less medicine for pain? So those are ways to see if this is something that's worth it for you. It's highly effective for back and leg pain. In the studies that have been studied on, it's been shown to be superior to traditional spinal cord stimulation. And then one thing is that it's paresthesia independent. The idea behind that is meaning that you're not sensing this sensation of buzzing or electricity. It's just working. Now you do have the option. That's the cool thing about the Nevro system, is that you can change it to different frequencies and get that paresthesia if that's what helps you. And some patients do like that, but most are very happy not feeling that kind of buzzing sensation. It isn't supposed to be addictive, meaning it's not a medication, it's a therapy. It's not supposed to affect or cause drowsiness like a lot of other pain medications do, including the ones I mentioned before. Going back to it, that we call it the Senza, that's the actual name of the system, is the randomized control trial. It was the largest, or is the largest, spinal cord stimulation trial for PDN, or painful diabetic neuropathy, over 200 patients. And again, 85% responder rate. Okay, so if you see that blue bar, it goes 80. It says 85%, meaning 85% people got relief, at least 50% relief in their symptoms. And then that's comparing it to conventional medical management, which is the medications, the therapy, anything that you would throw at it otherwise, other than this therapy. And only 5% of the patients got some relief in this trial from that. And then on the right side of the screen, you'll see that 70 patients had an average of 76% of pain relief in the study using the HFX 10 kilohertz therapy, as opposed to conventional medical management. So the idea behind the HFX therapy, again, is the quality of life. This is the whole, we're rounding about into how physical medicine and rehabilitation is what I like to do, what I practice. The goal is to help improve pain, hopefully. That may help you sleep better, may help you get around better, do your daily activities better. When you have less burning type pain, you may have perceived sensation as being more important and better and less painful. And hopefully you'll be satisfied with your treatment. Now, not everybody will. That's why it's 92% of patients were satisfied with their treatment in the trial, but it doesn't work for everybody. And that's why we have to go through the trial to see if it's worth it. So who's a good candidate? Okay, first off, specifically for this condition. Now, we can use, if you're listening and you're one of our patients and you had surgery for your back and other conditions, you may be a candidate for other reasons, but specifically based on this trial, HFX for PDN means that you were diagnosed with diabetes. You were trying conservative management, so you 2 or more medications for peripheral diabetic neuropathy. You're suffering debilitating pain related to the peripheral diabetic neuropathy, and then you want to either try to reduce or avoid side effects from other pain medications that may be harmful for you. We went through this before, so it's just kind of a rehash through it. So it's the 76% responder rate for back and leg pain, and then you have the painful diabetic neuropathy, which is 85%, and then a non-surgical refractory back pain is 80% compared to conventional medical management. So for superior long-term pain, this is just in general for HFX therapy, treating back and leg pain. They had more pain relief at 2 years compared to traditional spinal cord stimulation. So this is different from CMM or conventional medical management. This is actually comparing it to another device. This is comparing it to traditional spinal cord stimulation at 2 to 1200 hertz, 2 to 1200 hertz compared to the 10 kilohertz, which is the 10,000 hertz. 1.6 times perceived more relief compared to traditional therapy, traditional spinal cord stimulation therapy, with 67% responding. Now, let's talk a little bit about the trial again. On this picture, I wish I had a pointer, but the left upper side of the screen is the trial battery. That is where on the right upper side, that's actually the permanent type battery that's implanted underneath in your back area, underneath your skin. It's actually pretty thin and pretty small. You do feel it, but it's not considered bothersome for people after they've gone through the healing process. And you do have to charge it using a remote charger, which is on the left. And then you get a remote control to change the different programming. Some people find a good programming, they don't need a remote control unless they want to change something about it, increase the intensity, change the different programs. And then a lot of the software is remotely updated, as well as we have on-site representatives from Nevro who can come and test the device, make changes as needed to try different programmings. Maybe you get some pain relief and you want to try a different program and see if you get more. Those are the reasons to try it. Or maybe it used to work and not work after a while, and we got to figure out why it's not working. So what other things to expect? You want to talk to a physician. Now, I'm not the only physician in town that does this, but if you're listening to it, I'd love to, if you're interested in it and you want to learn more about it, I'm happy to talk to you. So you want to find a physician that does offer this. You want to be able to be a candidate. We would assess your medical problems, your comorbidities, make sure you've tried everything that would be conventional medical management or traditional medical management to make sure you're a candidate for it. We would have to also verify with your insurance whether or not you're eligible for it. Some insurances, most insurances cover it, but not every one. We would want to do the temporary trial. You would have to see a psychologist to get approval as per insurance rules. But once you pass through that, we get the trial done. And the trial, again, is about 7 days on average. You can go up to 10, but give you as short as 5 if need. And then the main risk of a trial is infection. So I put patients on antibiotics to reduce that. And that really helps out with any risk from that specifically. There is some minor discomfort during the procedure, which we get you through. We numb everything up, and there's no scar from the trial itself. From the implant, though, if you decide to go to the implant, it is a surgery. You would talk to the doctor, myself included, to see if that was worth it for you and that you want to move forward with surgery. And then we would run through making sure you're eligible for surgery from your comorbidities or other medical problems to make sure you can tolerate anesthesia. And then when we decide to do it, you are going to be implanted percutaneously, meaning the same way as the trial. We do have an option of doing what's called a paddle simulator, but that's less likely for patients. And then we basically, it is a surgery where you take a couple weeks to heal from with regards to the initial healing portion of it. But during that time, the stimulator is already on, and it's already hopefully starting to give you some benefit from that. After you're fully healed, then we can kind of fully assess whether or not we can change the programming and get you more relief. So before we go on to the next part, I want to show you, I have a model here. This is a spine model of the thoracic spinal cord. As you can see here, this is the, we call it the implantable generator, which is the battery. This is the thing that stimulates these electrodes that go underneath the skin and then into the spine, and then stimulate the spinal nerves in the spinal column, which is where the epidural space is. There is the spinal cord, and that spinal cord on the back side of it is the posterior epidural space, and that's where the leads sit. And the leads are what stimulate the spinal nerves, okay? So here we do a video. I think this is a step into the life of someone who has the nervous system.
Wife and a grandmother. My mom used to say, you're eventually going to have diabetes because it's in your family. Well, I've had diabetic neuropathy for probably about 15 years. I didn't understand why my feet tingled and burned, and they were always cold. And when I went to see my doctor, he said, you have what they call diabetic neuropathy. The pain would start from my back down to my hips, and then it just radiated down to my legs, my feet, my toes. I couldn't feel my feet underneath me. They were just cold all the time. I have broke my right ankle 4 different times. The pain impacted my life because I wasn't able to go out and do things with my boys when they were growing up like other moms and dads did. My family members would invite us to things and I would be like, I just can't, you know, because my feet are hurting really bad. My diabetic neuropathy impacted my sleep because I wasn't sleeping but maybe 2 to 3 hours a night. It would feel like I had knives scratching and digging into my feet all the time. I was just physically in so much pain that I couldn't stand to have my husband hug me, touch me, nothing. I thought, this is the end of my world. I'm going to die young. I'm going to not be here to watch my boys grow up, never see grandbabies. You just feel like there's no hope. After my HFX implant was put in, I felt almost immediate relief. I kind of describe neuropathy in your feet like 1,000 flies just buzzing. I didn't have that anymore. All the pain was gone. I can finally sleep at least a good 8 hours. I don't feel tired when I wake up in the morning. I feel like I'm ready to jump out of bed and take on the day. The HFX device fits into my daily life because it helps me to get up and do things, not have to worry about having all this pain at the end of the day like I used to have. My medication list that I had before was extremely long. Now I don't take anything for pain at all. It's been a whole different ballgame. I am able to do more things now that the pain prevented me from doing before. I'm able to enjoy cooking a meal for my husband, and I can do things with my granddaughter and my kids. I think they're a whole lot happier now with the mom they have, and that's what I enjoy about my life is I have no more pain. I don't have to depend on anybody else. I can finally start depending on myself. HFX is my best friend.
Okay, so we're back. So go over overall with concluding over our presentation today. PDN, peripheral diabetic neuropathy, affects a large population. And there unfortunately are limited treatment options, including medications, using creams and rubs and gels, using what's called the TENS unit, and then just controlling your blood sugar. Now, this HFX therapy, this HFX with 10 kilohertz therapy is the only FDA approved treatment for PDN. And again, to get FDA approval is actually quite hard. You actually have to prove with a study or multiple studies that the treatment does work. And so Nevro has done that. Nevro has shown that HFX therapy offers more pain relief than conventional medical management. It can help with decreasing the pain from the tingling, the numbness, the burning sensations compared to other devices as well. And then this is a treatment for patients who may have failed traditional management. And you can trial the HF10 therapy to see if it is worth putting it in permanently. And if it is, we can help you do that as well. So you will want to reach out to a provider that could do this for you if you're interested. If you're not sure exactly and you want to learn more about it, we can talk to you more about it as well. Okay, so thank you again for listening to this presentation, and thank you for listening to me. Again, this is our information, spinalnevada.com. Our phone number is 775-348-8800.